Yeah, hi, good morning. If you're going to take a couple of minutes, I'll wait, no problem. If you just have to go and come back, I have no issues. I'll wait.
You can actually, if you any emergency, I heard you have an.
Yeah, I have another case to operate myself. So
Okay,
I
so you just I think you just start. Try to make it very short and small and brief. So I will be happy. Okay, can you share your screen?
Yes, so thank you very much for accommodating, and I think I can skip the brief introduction and I can try to finish it as soon as I can. I'm going to talk about management of heart failure beyond ejection fraction. Basically, I don't need this adult audience to be sharing the classification and definition. So I'll skip to what I'm going to touch upon in terms of SGLT2 and why it's an important intervention for a cardiologist who does intervention, because this is one of the intervention that changes mortality. I mean, and I don't see between two stents, if you can define that, if any two stent, when compared, one would give you better mortality outcomes as compared to other. But this is one therapy, if you have intervened, irrespective of the class of heart failure, is going to work. I'm going to touch upon all the three important trials. Very important fear that people have is that empagliflozin or SGLT2 in a non-diabetic patient can induce hypoglycemia, which is not the case because glycosuria is proportionate to what amount of sugars are there. So in the serum, so glycosuria within 24 hours of single dose is not going to exceed 40 to 50 grams of glucose within 24 hours as compared to diabetics where it is much more. And this is driven primarily by the renal thresholds. The plasma glucose levels also don't change that drastically in non-diabetic patients. And primarily the therapy is proposed because of its multiple actions, again, which is beyond the discussion today. So I'm going to touch upon and take you through all the class of a spectrum of heart failure, and also we'll look at the acute heart failure. We all know about Emperor Reduced, which was one of the most important trial, which looked at the reduced ejection fraction outcome patients with empagliflozin versus the standard care therapy, and it resulted into 25% relative risk reduction with the first day of significance achieved within 12 days. I don't see any other therapy, including therapies like CRTs, that can give you results as early as 12 days in patients with chronic heart failure. And that's one reason why interventionists should also be aware about intervention like a therapy with an SGLT2, which can bring down an absolute risk reduction by 5.2% with only 19 patients needed to be treated for the same. And of course, remember, this therapy was effective irrespective of baseline diabetic or non-diabetic. It also lowers the risk in patients with reduced ejection fraction for end-stage kidney disease, which is one of the important aspects of mortality, with almost 50% relative risk reduction. In patients with preserved ejection fraction, even when you compare the Emperor Preserved trial with the ejection fraction for the 40%, also showed that the CV death and hospitalization for heart failure was reduced significantly by almost 29% in terms of mid-range and by 17% in preserved ejection fraction, again, irrespective whether the patient was diabetic or not. The risk of hypoglycemia or ketoacidosis in or with or without diabetes was as good as placebo. So it doesn't cause any side effect profile in terms of comparison with what you expect as an anti-diabetic therapy. So Emperor Preserved is one therapy which has shown risk reduction by 21%, and CV death and heart failure hospitalization has a significantly reduced as compared to other trials like Paragon, TopCat, iPreserve, PAP-HF, or Charm Preserve, where some of them actually did not have significant value reduction in terms of statistical significance. Now, when you look at this now plotted across the ejection fraction, in patients with reduced ejection fraction, you have net number to treat only 19, in mid-range only 21, and preserved only 42 to have a significant event reduction. And this is the pooled Emperor data across the spectrum. So this goes on to prove that in a patient with chronic heart failure, across the spectrum of ejection fraction, every patient can be given empagliflozin. Jardiance is indicated to reduce the risk of CV death and hospitalization in adults as class 1 indication. What about acute heart failure? We know that even in the Indian data set that we had from CSI Kerala Heart Failure Acute Registry, patients who were on guideline-directed therapy compared to those who were not, the in-hospital mortality continued to be pretty high, 7% versus 90-day mortality of 11.6%, rehospitalization of 11%. And the reason for deviation was often believed to be the worsening of kidney failure, hyperkalemia, or hypotension. So EMPULSE was primarily looking at for post-acute heart failure, where they looked at the evaluation with a win ratio defined as a composite of death, number of heart failure events, time to visit a first heart failure hospitalization, and the KCCQ-TSS score at 90 days. So all of these criteria must apply for the inclusion. Was required that the patient's blood pressure was more than 60, more than 100 for more than 6 hours, no increase in diuretic dosages in IV, no vasodilator, including nitrate within last 6 hours, and no inotrope in last 24 hours. And they looked at the all-cause mortality in heart failure hospitalization, and you can see the benefit was consistent in acute heart failure onset, de novo or chronic, whether EF was less than 40 or more than 40, whether the patient was diabetic or not, and the adverse events were pretty much matching for the placebo arm. So when you compare this with the various other trials like Soloist, where the cetagliflozin was looked, Galactic, where even omective mecarbil was evaluated, Victoria, where Verisigua was evaluated, Pioneer HF, where ARNI was evaluated, Impulse is the only trial of the therapy where it met all the criteria: reduced ejection fraction, preserved ejection fraction, diabetic, non-diabetic, and 100% patients were initiated this during in hospitalization. So optimizing the place in heart failure therapy would hence mean the four pillars. The four pillars, when you combine the ARNI, beta blocker, MRA, and SGLT2, your hazards goes down by 64%. Its hazards is just 0.36 as compared to, say, Verisigua, where it's not that much down. So this, even omective mecarbil or Verisigua combination with MRA, all these trials have been superseded with fantastic results with these classical four foundational pillars, as the ACC talks about: beta blocker, SGLT2, RNA, and MRA. So you need to just ensure EGFR is more than 30 and the E for DAPA and more than 20 for EMPA for the initiation. The 2022 strongest recommendation that has now come as 2A in patients with mid-range ejection fraction. Also, SGLT2 is beneficial in reducing the heart failure hospitalization and CV mortality. Milton Packer's group has suggested combining beta blocker SGLT2 ahead of ARNI, and this is when you're going in a stepway fashion. But in our part of the world, I assume a lot of patients may not be able to come back to you every weekly for up titration in 3 steps. Very often in our practice, we do initiate 3 or maybe all 4 of them if the blood pressure and the clinical hemodynamics and potassium hemostasis and renal functions are good enough. So patient-centric favoring and tailoring of the therapy is important, and this is a position statement from Heart Failure Association of European Society of Cardiology. Patients with hypertension, increased heart rate, or either of those combinations that you can see on the right side, on the left side of your screen, SGLT2 should be given to all of them. So you may have other therapies coming in and going out, but the SGLT2 has remained a pillar irrespective of heart rate, blood pressure, atrial fibrillation, hypertension, CKD, pre-discharge, post-discharge. All of them can actually be given SGLT2, irrespective whether you can give other therapies or not. And this is a position statement from Heart Failure Association of European Society. The advantage of Jardiance being that it needs no titration. There is nothing to do with the heart rate, nothing to do with blood pressure, nothing absolutely to do with sugar. You can leave your anti-diabetic management therapies to be tailored by a diabetologist friend. But I believe all interventionists should insist to intervene with this therapy being single dose once daily, no titration. Thank you very much. I hope I stuck to the time.